I'm honored to be here with you today at the UCLA CHIPS HIV Next Generation Conference. As was said previously, my name is Amaya Perez-Brumer, and I'm a critical global health scholar trained in both public health and sociology, and an assistant professor at the University of Toronto. Today, I will be asking you to join me in thinking through who benefits from global HIV prevention science, and what is our call as researchers to move towards accountability. So this talk is given from Tekaronto, a Haudenosaunee word known in English as Toronto. Toronto consists of ceded land covered under Treaty 13, as well as unceded land that continues to be contested. I would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, the Anishinaabe, Wendat, Huron, and the Haudenosaunee Indigenous peoples on which the University of Toronto now stands. I also recognize that as a settler living on stolen land, I benefit daily from the ongoing violences and the legacies of colonialism. I have an ongoing responsibility to learn about the land that I am living on, cede power to Indigenous people, and amplify ongoing projects of Indigenous resurgence and sovereignty. So I am Venezuelan American, and now after a little bit more than 5 years in Toronto, a Canadian permanent resident. Spanish is my first language, and I identify as Latina. It is telling that I'm afforded the honor and the privilege of being here with you today. I am a cisgender woman, and I do not take lightly the privilege of being here. And I must underscore that my scholarship is deeply indebted to my Peruvian teachers who push me daily to recognize and grapple with the extreme privilege and power at the center of who gets to do global health research. As an HIV prevention researcher, my work centers on the making and the analyzing of data to improve HIV prevention efforts, and as a social theorist, the analyzing of the making of the data. So who gets to do health research? Who are its beneficiaries and who are its subjects? Specifically, I study the ways in which power, sexuality, gender are entangled with contemporary approaches to HIV science. On this slide, you will see a photo of various members from Feminas, a community-based organization in Lima. The text is small, but underneath the photo it reads, Peruvian transgender women say they want more leadership roles in studies involving them as subjects. I want to be clear that politics and power are central to my talk today, and thus I want to draw your attention to the word subject. What might it mean to be a subject of HIV research? How does research act as a form of discipline and perhaps a form of social control? Learning from trans women in Peru, where I've been conducting research from 2009, this talk is meant to be a provocation. As relevant to the conference theme, implementation science for HIV prevention and treatment to end the epidemics, today I ask you to join me in reflecting on our own social location, our privilege, and most importantly, our responsibility as researchers. There are great upheavals in global health today. We have activists globally to thank for ongoing demands for change and to reimagine a more just future. Thank you to those who name and evidence the ongoing work of colonialism, white supremacy, capitalism, and other violences, and the work that these do to uphold the power and privilege of a few, including myself, who do global HIV research and earn a living doing so. We as scholars and as practitioners of global health have work to do. There is simply too much at stake. This is our call and the call for the next generation of HIV researchers and practitioners. So to imagine and to reimagine a more just praxis for HIV research globally, I ask you to join me in sitting with the discomfort of the following questions. Does HIV research make health, or does HIV research make data? How can we ensure that science and knowledge translate into tangible health gains. Now, let me tell you why I ask these questions and why I believe that these questions get us to the heart of extractive data logics in global HIV science. First, we need to consider big shifts in HIV science that have been fostered to date. The fourth decade of HIV and AIDS has ushered in a new era of how and what research is conducted, with an explicit focus on pharmaceutical-based prevention and new technologies at play. The advent of pre-exposure prophylaxis is a remarkable innovation to prevent HIV acquisition. Its development has led to a boom in research among populations considered to be most at risk and then most in need of PrEP. Oftentimes, people classified as men who have sex with men, MSM, and especially transgender women globally are central to this focus. The shift to prevention and the emphasis on certain groups necessitates a rethinking of the politics of the data extracted from people of diverse genders and sexualities in the pursuit of HIV prevention. And this is our call as researchers to better understand our role in accountability. For my career, I have and continue to work on HIV prevention for communities at heightened vulnerability for HIV. Most of my work has been in Peru. Peru has been central to the testing of HIV prevention strategies. Take, for example, that Peru contributed more than 50% of the global sample for the watershed IPREX study that sparked significant changes, both for global policy and associated scientific actions to support PrEP for HIV prevention. Yet today, more than a decade after PrEP, the evidence continues to reflect a burden of HIV among the very communities, namely gender and sexual minorities, that participated in and supported in the advancement of this prevention knowledge. Why? There's a need to examine how HIV biomedical prevention incorporates contradictory practices that can perpetuate existing inequalities. So I need to say this another way. When I first started working in Peru, available convenience samples evidenced that HIV prevalence among trans communities was around 30%. Last month, our own study with young trans women aged 18 to 24 evidenced that every 2 out of 5 women who participated in our study, or 40%, were currently living with HIV. This is shocking. Since 2009, I've been involved in numerous studies targeting this population with total funding of above 5 million USD. So I ask you, what the hell is going on? Obviously, there's a lot going on, and there's a lot to account for. Yes, I've been pushed to think through the limitations of this example. These are convenience samples. This isn't the same population. What about COVID-19 effects? But to me, these questions are irrelevant when faced with this dire reality. 2 out of every 5 women in our current study are currently living with HIV. To seriously start disrupting how global HIV science operates and understand what it needs to be changed, I want to share with you 3 lessons that I have learned from Peruvian trans women. The first lesson, why more research and not more health, underscores the discord between the increased frequency of PrEP research targeting trans women in Peru and the limited actual improvements in HIV outcomes among trans women. The trans women who shared their experiences participating in HIV prevention research often described the choice to participate as complicated by the limited HIV prevention and care options for trans women within the existing healthcare system. Even those who noted the importance of HIV research for access to care were wary of the surge of clinical trials and noted that the health impact for trans women in Lima was limited. Care was often described as ephemeral, and HIV acquisition frequently posited as inevitable. 27-year-old Danica told us, "I participate in studies now so that I can get care, but what happens once I get sick? These studies end." While many participants said that they valued the care provided by studies, they questioned the lack of long-term health benefits for trans women. And this was further complicated by wariness of foreign investigators, perceived to be driving PrEP research agendas. For example, another participant, Maria, noted, "How long have gringos been researching us? Why are we still getting sick? What will I do if I get sick, if I get HIV?" The second lesson centers on reframing research processes as a research marketplace, underscoring the political economy through which global health data are produced and circulate. For example, while observing operations of an ongoing HIV prevention study, Maite, a peer recruiter and study staff, commented, "Several of the travesti are coming in and don't understand the word transgender and don't identify as transgender. This has become a problem on the survey since they are leaving this question blank. And Dr. Smith has emailed me twice now about missing data on surveys." To this, the leader Yasmin responds, "Tell them that travesti is the same thing as transgender and the surveys were written by gringos. Plus, if she wants to continue in the study, continue getting PrEP, and continue getting money, she needs to fill out the survey completely." This interaction demonstrates the politics implicated in creating data to meet the needs of the research economy, the active practices of minimizing missing data for quality exportation. This example also highlights the uncomfortable tension within gringo-designed research that lacks contextual relevance. Travesti is a term to describe trans feminine identities that is closely associated with street-based sex work and often reflects a lower class with improving society. So is travesti really the same thing as transgender? And if not, why say it is? This example leads us to question not only the value of the data that is collected, but the coercive nature of the process itself. The third lesson highlights the contradiction that PrEP is a key HIV prevention technology that has been tested repeatedly on trans women, but is not readily available to them, furthering the belief that their community is not actually PrEP's intended users. As noted in a formative focus group, one participant told us, "Why are we trans women being used like guinea pigs, every single one of us?" This disjuncture was further amplified by the conflict between the short-term rewards, so providing financial incentives and temporary access to new medications, against long-term public health failures, leading to limited access for successful therapies and care. As described by another participant, Angelica, "What can I tell you? Do I have a problem that my community is treated like an experiment? Yes, but we continue to participate and work for these studies because we are seen. We at least get some HIV care, sometimes we get PrEP, and we even get paid." These brief examples, while alarming independently, must be held together. Jointly, the tensions reflect extractive logics at the center of HIV science and global health. As Johanna Crane argues, global health science is the uncomfortable mix of preventable suffering and scientific productivity that paradoxically embodies and even benefits from the very inequalities it aspires to redress. In listening to and learning from trans women, there is wisdom in their research mistrust, in mistrust of a system that privileges and replicates extractive data practices. As such, hesitancy, mistrust, loss to follow-up, or enrollment cannot be understood as a trait of trans women to be addressed solely through education about the research process, but as a justified response to systemic inequities replicated by and manifested through the extractive logics of research. Their mistrust is a learned community insight that underscores the inequities between communities, researchers, and the research enterprise. Yet, there's also another piece that must be underscored to understand the pervasiveness of these paradoxes in global HIV science, research in Peru and beyond. This additional piece is the value driving extractive data practices. Academic research begets more academic research, producing scientific knowledge as global currency. This is true for scientists and researchers like me, who realize that the ability to secure funding and progress through the ranks of academic promotion depends on participating in this research economy. To illustrate what I mean by describing our field as an economy, the image shows the process of data transformation and the value accrued at each stage, from the collection to the entrepreneurial opportunities presented in the collection, management and analyses of data, to the knowledge dissemination, typically in forms of publications and conference talks that yield scientific capital through acknowledgement and career advancement. Manuscripts operate as the ultimate record keeper of a scholar's scientific reach, and they are essential to demonstrate expertise and acquire grants and serve as revenue-generating assets that indicate ownership and expertise. Jointly, these processes, individually and collectively, foster systems that maintain and sustain the HIV enterprise on a global scale. While presented linearly, this is far from true. These processes are messy, they're complicated, and they have differential gains. Here, it is helpful to point to the reality that many US scientists have enhanced their own careers by being trained in Peru, and this includes me. And yet, when speaking to Peruvian researchers about their professional relationships with US investigators, many scoff and refer to international health researchers' imbalance of power. Importantly, this imbalance is systemic. Take, for example, ownership of knowledge dissemination. The path to establishing expertise is understood to primarily apply to investigators from the global north, namely the United States, and many of the most senior Peruvian collaborators. For example, Juancito, a Peruvian project coordinator with more than a decade of HIV research experience, a Peruvian medical degree, and a US degree in epidemiology, described, "Publications don't really help me keep a job. They would be good, but I will never be a leader of HIV research in Peru. That role is reserved to US investigators." Power imbalances described by Juancito in knowledge dissemination are a symptom of greater systemic fissures. To further disentangle notions of imbalance, it is important to describe how funding is distributed and operates. As we all know, and we all probably know too well, NIH funding awards include direct costs, expenditures budgeted for scientific research and listed in the public domain, and indirect costs, defined as expenditures related to facilities and administration. NIH does not determine indirect costs. Rather, each US academic institution establishes their own fee. However, NIH does limit the number of indirect fees that a foreign institution can charge to 8%. So just to give you a range, I mean, you all probably know this much better than I do, but across the institutions that I work with, being UCLA, Harvard, Columbia, the range is somewhere between around 57 to 82% indirects, compared again to an 8% cap for foreign institutes. This simple example illustrates two key points. The first is the systemic imbalance between US-based and foreign sites with respect to funding allocations. While this relates to indirect, not direct costs, it's important to note that at least in the case of Peruvian HIV studies, 8% indirect cost does not cover expenditures related to facilities and administration when the majority of the work takes place in the foreign site. The second point is that the structure of funding has created a context in which scientific research is an enterprise, not only for researchers, but also for academic institutions. So at this point, you're probably asking yourself, but wait, wasn't this talk about learning from trans women about the harms of extractive data practices in HIV science? Yes. And these lessons, we cannot learn from these lessons without recognizing the larger systems at play. To begin to consider actionable improvements to HIV biomedical research, It is critical to draw attention to the multiple forms of power that underlie the politics of HIV science, which impact all involved in this enterprise. The story of extractive data practices traded on a global economy is not unique to the contemporary HIV industry, but rather a key element of health research, which frequently leverages made vulnerable communities that participate in this research and that we are meant to serve as a living laboratory. The lessons and tensions that I'm sharing today should not be understood as something that's happening over there in Peru. Rather, my hope is that these three lessons presented today, why more research and not more health, the economies of research, and are we just guinea pigs, will resonate with many of you doing this work day to day, those of us who actively seek to ameliorate the pervasive disparities that shape vulnerability to HIV. And yet, when making these arguments, I'm often met with comments from colleagues who push back and advocate for more active allyship, suggesting that a possible way forward is better community relations, more robust community advisory boards, methods and designs that are co-developed with community. And my answer to this is yes, but yes in part. The other part, which must go hand in hand, is the recognition that there are greater systemic issues, namely the tenets of capitalism, that are intermeshed with global HIV science and practice. Namely, the push for more data without the push for more health. While the imbalance of funding and indirect direct funds is just a small piece of the puzzle, it is quite illustrative of the inequities built in and replicated by the system. The call to action for the next generation is not as simple as to deal with indirects. I wish it were. Rather, our work and our responsibility as researchers lies in actively recognizing our role and the part we play in the perpetuation of extractive data and the benefits received. This is the first step to rectify broken trust between community and researchers. And this is the base from which we must start to imagine, build, and sustain a more just HIV science. In the work to come, let's remember and remind each other that when we do not name capitalism, colonialism, racism, heteropatriarchy, and other intersecting modes of oppression, the possible harms of research are too easily ignored. Our call for equity and a more just imagining of what HIV science can and should be cannot be divorced from an examination of the role that power and politics play in the perpetuation of extractive data practices. The two photos presented here highlight the strength, power, and ongoing solidarity enacted by trans and gender non-binary people in Peru. This is my reminder of who I am accountable to. So yes, let's push, let's fight, let's advocate, let's join those brave enough to call for a disruption in HIV science. But in doing so, we need critical reflection, awareness of the role that we as researchers play in the system and how the system is broken. It is only then that we can move towards accountability. So for the next generation of researchers, to enact change, we must underscore that HIV and HIV science is political. To listen to and learn from made vulnerable communities that we are accountable to, justice and solidarity must drive our praxis. This depends on authentic community relations and co-learning and requires funding, not solely as peer recruiters or in a community advisory board capacity, but real money for and to acknowledge the labor of grassroots organization, the brilliance of community members, and the dedication of global partners to make the research happen. And funding to support health and not data necessitates bearing witness to the violences perpetuated by the system, to disrupt and to invite change. Hope for change is necessary, but in the wisdom of the late Paulo Freire, my hope alone is not enough. Rather, we need critical hope as a collective and iterative praxis. We need to take action by learning about and from the discomforts, the contradictions, and violences of global HIV science to move towards and reimagine the possibilities. In an aim to stimulate reflection and critical hope, to end, again, I ask you, why more data and not more health? Who benefits from the data? And who is responsible for addressing the oppressions that yield pervasive and growing health disparities? Thank you, and I look forward to continuing to think through these issues and engaging with you with any questions, comments, and recommendations.